So let me go through the outline of the talk, and I'm not going to go too slowly at the beginning because I want to get more to important things near the second half and the end of the talk. So I'm going to rush a little bit at the beginning, but I'm going to talk about prevalence of suicidal thoughts and actions. I'm going to differentiate between the client who is acutely suicidal and the client who struggles with chronic suicidality. In other words, they feel suicidal most of their entire adult and often teenage life. I'm going to talk a bit about suicidality, why people feel suicidal and what's the function of it, and follow that up with a hypothesis about the developmental origin of suicidal thoughts, particularly for those with chronic suicidality. And chronic suicidality is really, all my patients with borderline personality disorder have chronic suicidality, but there are other patients who don't have borderline personality disorder, but have the same problem that they're chronically suicidal. But much of my talk today, particularly around the chronic suicidality, will be around using my experience of working with patients with borderline personality disorder. I'm going to talk about therapists' fear of suicide, of the client's suicide, and how that impacts on our therapy. I'm going to talk about what you do need to do to manage the patient with chronic suicidality, something that lots of people struggle with. So here are the predictive factors that have been shown in associational studies. These are studies that show that there's some kind of association between suicide and these risk factors. It doesn't mean these risk factors actually lead to suicide. And this is a review done by Brodsky and Stanley for 2008, but it's a pretty standard list. Previous suicide attempts, self-harm, as I mentioned before. Depression, PTSD, or panic disorder are associated with suicide. Clients who are isolated, either single or have few family or social supports. This only works for men, not for women. Family history of suicide, particularly a parent. Family, growing up in a family with emotional chaos. Childhood sexual abuse is more predictive than childhood experience of violence or witnessing domestic violence, but that's also a very slight factor. Reduced serotonin. In animal studies, maternal deprivation in primates, that if you deprive monkeys of their mother, then they become more aggressive, more impulsive, and they show suicidal tendencies. They try and hurt themselves. And the protective factors. Caring adult, growing up with a caring adult. Growing up in what de Jong calls a connected family, where the parents are emotionally available, and this is a proxy for a secure attachment. Having an active sporting life growing up. Growing up in a family with religious or moral values that then extend into your adult years. Being female, males are 3 times as likely to kill themselves as females. So this leads us to the myths of risk assessment. I mean, often in public health, I get told and I get sent instruments that are supposed to measure risk. And the problem here is, can suicide be predicted using those predictive factors? What about the risk factors? So for example, if I have a single 19-year-old male with several suicide attempts who's depressed and grew up in a chaotic family, what is the risk? The risk that this man will kill himself is still incredibly small. In other words, the usefulness of all of these risk factors is 0. Studies of trying to predict who will kill themselves using risk factor analysis don't work. All the instruments that you might have seen don't work. They're done for to make us feel better, to make our management, in my case, in Hunter Health, management structure feel better, but actually there's no evidence that they predict anything. But first, let's ask why therapists are fearful. I hope you're fearful of suicide, of your patients' wish to die. I am. It would be kind of weird if you weren't and you cared about your patients or your clients. And if they tell you that they're suicidal and you're not scared, well, that would be strange. But there are reasons why we get scared. Of course, the most important thing is we don't want to lose a client, particularly once we've got to know them and got close to them. Therapy of any sort is about getting close to our clients so they become emotionally important to us, just as we become emotionally important to them. But we're also scared because we fear that we'll be seen as a failure professionally by our colleagues, by the community, by the family, etc. We're also fearful because often we feel impotent or helpless and hopeless in the face of the power of people's suicidal thoughts. We're worried that we will be blamed if they kill themselves. And of course, we're worried about medico-legal consequences, which I'm going to talk a bit about at the end of this talk. So when your chronically suicidal patient says, I'm suicidal, they walk in and say, I'm feeling really suicidal today. What do we feel? As I said, mostly it scares us. And what do we do when we're scared? With anything that we're scared about, we look for safety. And these are the kinds of things people usually do to try, therapists do to try and feel safer. So yeah, it generates fear, as I just said, which means that we look for safety, and this is how we do it. One of the classic things to do is to reassure the patient. You're a good person, you'll have a good life. We try and talk them out of it. You've got good qualities. There's hope in the future. Things will get better, etc. Sounds reasonable. Or we get a bit more heavy about it. To my shame, one of the things I've done many times is try and coerce the patient out of being suicidal, make them sign a no suicide contract, which, by the way, there's no evidence that they work, even though some services insist on them. When they've been studied systematically, they have no benefit whatsoever. But we try and push the patient into complying with a contract. Or one that I've used, say that your kids will never recover entirely if you kill yourself. And so you think you're doing a favor to your kids, but by killing yourself because you're such a horrible person and you're a drag on their lives, but in reality, they are going to be hurt by this and hurt in a very profound and long-standing way. It sounds, it's quite powerful, it just doesn't work. It makes things worse. Or we may avoid what is frightening. I didn't hear that. Or I'll just gloss over it, or we'll talk about other things. Or we suddenly panic, or don't panic, but suddenly move into action. We get help. We figure out a suicide risk assessment. We go and get the community mental health team involved, or their GP involved, or the family involved, or put them in hospital. Or sometimes we get angry. We feel helpless and hopeless, pissed off, particularly if it's been many times, or it seems so unfair. We may get annoyed with the client. Or we may become as helpless and despairing as they are. These are common things. I have experienced all of them at different times. But I also know from years and years of work that none of this helps. So let me finish, not finish, but get to near the end of the talk. I've gone a bit faster than I thought, so we'll have more time for questions. But I want to talk about medico-legal things because people worry about medico-legal aspects of a patient's suicide. And I think, although I understand why people are worried, and I get worried too, most clinicians are much more worried than they need to be. And I'll explain, which is a good news story. So firstly, my experience of medico-legal, going to coroner's court, and I've never been sued, but going to a coroner's court where the coroner investigates a suicide. And I've had 3 patients under my care, none of them fortunately in psychotherapy, all of them when I've been doing general psychiatry, where I've had to go to the coroner's court and explain. And my experience has been that the coroners are not interested in blaming me or you or any individual. That's not their brief. The coroner is there to look at what as a system can we do differently. Unless someone is criminally unless you did something criminal, which is very rare for therapists, very, very, very rare. The coroner's not interested in that. They're interested in the system situation. That's their brief. And that's I've found in the 3 times I've been there in the coroner's court. It is a real issue, though. Two surveys in Australia show that 50% of psychiatrists and 20% of psychologists in their career have had a patient suicide. However, this is more common, much more common in public, for public clinicians than for private clinicians, but it's still high. And it has a powerful impact on people. So don't underestimate the impact on you, the emotional impact when your patient suicides. But what's the risk of litigation, of actually being sued? The risk of litigation, and this is statistics from the United States, which is much more litigious, much more likely to litigate in the US than Australia. So even in the most litigious society in the world, these are the stats. A very small fraction of patient suicides go to litigation. I think it's under 3%.